Welcome to the Health and Wealth Power Hour, the podcast that provides you with the knowledge and insights you need to achieve physical, mental, and financial well-being. I'm your host, Harlon Pickett, a business consultant who's passionate about helping people achieve a more balanced and healthier life. Each week, we'll deep dive into topics related to health and wealth, including retirement income planning, innovative healthcare solutions, alternative funded health plans, and specific actions individuals and business owners can take to gain control of their finances, have access to affordable quality health care, and achieve peace of mind. We'll also be joined by innovative experts who will share their knowledge and insights on prevalent topics. So, whether you're looking to grow your wealth or improve your health, you've come to the right place. Get ready to be informed, inspired, and empowered. Let's get started. Well, welcome to another exciting episode of the Health and Wealth Power Hour. I am your host, Harlon Pickett. We are super blessed to have round two today with Dr. Ravi Iyer. We had such a great conversation last time, and we covered so many different subjects that I felt like it was imperative that he join us again and share his views on a couple of other things that I feel like he brings big ideas to the table. And the first thing we're talking about today at his request, and I really love this, is leadership. And leadership specifically in the healthcare space. That obviously is very near and dear to our heart as well. And working in this space from a different angle, of course, but it is certainly something that we deal with all the time. We deal with leaders across the healthcare world in our goal to bring healthcare access to folks, no matter where they are. You know, we send some messages back and forth to one another. And I was very, very excited to see that that's what the direction you wanted to go with this particular episode, Dr. Iyer. So tell me a little bit about what brings this topic to mind to you, that you felt like this was a great place for us to venture into in round two.
The concept of leadership is not new. It's already there in a lot of industries, and a lot of industries approach leadership more consciously and directly than in the healthcare industry. Healthcare industry, the concept of leadership is not addressed as directly as, for example, corporate America addresses leadership. And so, but it's there nevertheless. Whenever you have a group of people, automatically there are groups of leaders. One of the reasons for that is healthcare has evolved out of an amalgam of cottage industries. So each physician is a leader of his or her team, and each practice amalgamated into a larger corporate structure, but it is still a conglomerate. It is not an integrated leadership structure. But with the evolving vertical integration of healthcare systems, you have, for example, United Healthcare, which is the dominant player in the market and is acquiring primary care practices all over the place. And you have large number of integrated healthcare systems. The idea of leadership is becoming more and more imperative in the healthcare industry. And obviously, when they talk about leadership, everyone jumps into the concepts that have worked in other industries, but the economies and the imperatives of healthcare is uniquely different than from, say, the automotive industry or the high-tech industry, where here you are dealing with both humanistic features such as altruism, common good, public good, as well as private good. So you have the need for profit and and you have the need for uh, a fiscal growth. At the same time, you have to serve a larger communal good in terms of involving the betterment of the health and well-being of a large community or a large population. So in this unique conundrum, leadership and the ideas of leadership are slightly different. And that was the reason why I wanted to talk about it, because it is not leadership as it is practiced in the domain of healthcare has some unique characteristics that sets it apart from the leadership that is commonly practiced in the rest of corporate America.
Yeah. So let's talk a little bit about the dynamics of that then when, as you mentioned, you have a big entity. You mentioned United Healthcare. They're not the only ones that have purchased. I mean, we've got private equity groups. You've got other insurers. You've got like even Walgreens, Amazon, right? We have a number of folks getting into the healthcare world that are kind of not what you would traditionally consider healthcare players, whether it's an insurance company or whether it's a pharmacy or whether it's the folks you buy all your stuff from online, jump into this world. When this happens, when you have basically for-profit big entities come in and purchase practices or surgery centers or whatever they're going after, you have two different mentalities of leadership then, right? You have almost a corporate America type leadership that they're looking for profits and they're looking for those things versus that different healthcare. We're taking care of people. We're fixing things. We're making things better. You've got those two different things. What have you seen as some of the major problems that can happen with that? It really go in both directions.
The way I talk about leadership in healthcare, when I talk to hospital groups or even large practices, is I talk about the basic unit of healthcare is the patient care team. That is the integral basic unit. And that team consists of three individuals. It consists of a patient, it consists of a physician or a provider of the care service, and it consists of a nurse. This triad is the core unit around which the entire industry is built. So what I tell people is start with the root, and then you start building the tree and the shoot and the trunk and the branch. Most people, they start with the whole tree and then say, okay, how am I going to go down to the root? But if you start working from this core unit and you say, okay, this domain of leadership, where does leadership actually begin? Now, everyone talks about leadership as if it is something that you can go to college or you can go to a graduate program and learn leadership. Leadership, like bicycle riding, is not a learned skill. Now, when you are on a bicycle, the idea of balance does not come from just sitting on a bicycle. It comes from falling. Balance actually comes from falling. And you need to, and in the initial stage, you are on the bicycle, and the sensation of balance versus imbalance, these two sensations, you are not able to make the distinction between them. You are not able to make the difference between them. And therefore, you fall because you don't know what is balance and you don't know what is imbalance. And therefore, gravity being always operational tends to always pull you into imbalance and you fall. later, after you've fallen enough number of times, you start beginning to distinguish when you are in balance and when you are not, and then you start automatically, unconsciously doing things that perpetuate balance as opposed to imbalance. And suddenly, voila, one day you are able to drop the training wheels and you're able to ride a bike. And most people think that leadership is something that you can learn from reading case studies and textbooks. But in actuality, leadership comes when you are able to create a team that allows error to happen in a safety net. Right now, most healthcare organizations have a big problem with the idea of handling error. They expect no error right from day one. When I work with teams, I tell them, you are free to make mistakes. My job is to pick and provide you the safety net that allows you the freedom to learn through mistakes. This concept of leadership and this concept of team building is what eventually creates a robust entity. But most organizations have problems setting up a system to learn through error.
Yeah, because that's kind of our human nature, right? We don't mistakes. It's got to be someone's fault or something. Where that's kind of we think of it always as a negative. But if you don't make those mistakes, like you said, if you don't fall, how can you get back up? How can you learn the right way if there wasn't a mistake? It's the old thing of who was the first one to do something, but someone had to do something wrong, most likely, before. How do we know which mushrooms are poisonous?
Somebody had to find out.
Someone found out, hey, this one tastes good, but later on they didn't feel too good. This one tasted good, and later on it felt just fine. I wanted some more. Right? So, but whatever it is, there's got to be somebody that kind of made a mistake along the way.
Right.
That you learned, or there was a learning process that went through there. But once again, this conflicts though, right? There's a conflict there with that type of learning and that type of leadership with, if there's mistakes made, that's affecting my profitability, says the corporate America leadership that's only basing everything on profit. And the leadership you're talking about is patient-centric. You mentioned that in that triad. Where is it? The patient's part of that decision-making. But in the profit-based healthcare, that patient and even that doctor and nurse, they're discarded. And in many cases, the decision on what type of treatment or medication or whatever that patient gets is made at a corporate level based on profit, not based on actual evidence-based medicine.
Yes. I tell patients this all the time, and they come and say, why is it that this, why are they denying me the medicine that is obviously going to produce value? And I tell them the reason is they already figured out that what is the cost of, if you were to get a heart attack, how many heart attacks can they bear before, as compared to, for example, we were talking about, a patient asked me recently, he was getting this medicine, Monjaro, which is the new diabetic medicine. It's actually phenomenal, that drug. And it produces a dramatic drop in his A1C, and he drops his weight, his cardiac risk goes down, his cholesterol numbers become normal, and the insurance doesn't want to pay for it. And I said, and the patient wanted to know, why is it that the insurance won't want to pay when they know that this drug is going to prevent him from going to kidney failure and having a heart attack? And I said the reason for that is they have already figured out that for every 100 patients who are on Mounjaro, their cost for 100 patients for the next 5 years, which is the time it would take to save you from your heart attack. Out of these 100, they have already figured out in the next 5 years, only 5 heart attacks are likely to happen. And each heart attack is going to cost them only $50,000. So their savings over a 5-year period by preventing 5 heart attacks is $250,000. Whereas their cost of giving Mounjaro to 100 patients for 5 years is $5 million. You do the math, which is it that they are going to use? So they have already figured, and he said, that is horrible. I said, yes, it's horrible for you because you are the one who's going to get the heart attack, but it's not horrible for the insurer. The insurer has already figured out that they would rather go home with $4.5 million as opposed to spending $5 million. Yeah. Oh, no, it's not. It's that's the way they are planning it out.
So let's touch on that for a second, because and I know this is kind of slightly off the leadership thing, but I think one of the more interesting things is the insurance companies make these decisions differently based on where or who the actual payer is. And I know insurance companies are called payers, but let's be honest, they ain't paying nothing. Who's paying? We are, or the employer is, or the employees are, right? The real payers are the people who actually have the coverage. They're the ones paying the premiums, right? And the employer's on a self-paid plan, and they're the ones paying, even if one of the insurance companies is administrating it. But my point there is, across these different plans, whether someone's on Medicare or someone's on a commercial plan or someone's on a ACA plan or someone's on Medicaid, or you can be getting your coverage or your insurance from different places. Just talking about, say, Mounjaro, it may be covered on 1 or 2 or 3 of those, but rarely, unless it's a generic medication, is a medication covered across all of them. Especially newer brand name medications, it's almost like they pick or choose what they'll be covered on, but not on others. And I understand in self-funded plans, the employer typically decides what's going to be on their formulary in many cases. But if the insurance company has a say in it, I always thought it was interesting how it's on a formulary for this, but not on a formulary for that. And it really kind of comes back to what you just said. It's how much money am I going to be paying for it, and how much money am I going to lose by covering it or not covering it, which that's all it's about, right? That's, once again, it's putting profits over patients.
Yeah. So the insurance companies work on the model of actuarial risk, and the actuarial risk is based upon what they call the loss ratio. And they have a word for it. It's called the medical loss ratio. And so they actually consider paying for healthcare as part of their medical loss. It's very ironic that they actually use the term actually on their books. They call it the medical loss, the fact that they are paying for that. And one of the problems of risk and distribution of risk across large populations is this idea that you can pay for bad, risky patient care through the postponed risk of healthier patients. So every patient, if you live long enough, is going to get every disease. So the idea then is that you have enough younger patients who are unlikely to get sick, paying premium, which they will not use, that will be used to cover the cost of older patients or sicker patients who are going to use those premiums to pay for their care. So eventually, on a philosophically or a moral level, you are basically robbing Peter to pay Paul. And it is no different than a shell game, or it is it is no different than a Ponzi scheme where somebody it is a Ponzi scheme. Entire healthcare financing is a Ponzi scheme. And it's ironic that you have a Ponzi scheme that is institutionalized in the form of medical insurance, but when it is used in the rest of the stock market, you have somebody like Bernie Madoff being sent to prison.
Yeah. Well, so one of the challenges of modern day healthcare leadership, such as yourself in a practice, right? You're the leader of a large physician practice, is dealing with these entities, right? Whether you're owned by an insurance company or private equity or you're not, you still have to deal with them. You still have to submit claims. You have to still get paid. And we talked for a second about the craziness that's still going on with Change Healthcare. But regardless of whether that you had that data breach, you worked through these systems, these clearinghouses previously. You'll work with them in the future because you got to get paid, right? And that's part of the way you do that. So talk about some of those challenges that you guys have in one of the most basic things of all, and that is getting paid. How difficult is it in a more traditional sense? I want to kind of step back before we had the issue with Change, before we had the data breach, and things were running as smoothly as they possibly could, whatever that looks like. I'm just interested, and I think our listeners will be too, on what it's like to deal with all of these different entities and the processes that they require for you guys to get paid. What does that look like?
So if I have to process a claim through the mechanisms that are used by insurers, so I have to see a patient, document it the way they want me to, so that they can justify paying for that service. And I have to process my referrals and do the prior authorizations for various medications and all that, and have the staff for doing all of that. Have a billing person that will submit the claim in a way that will get processed through the systems. Have claims, an office manager to review unpaid claims and work the AR and so on and so forth. I need to, for a single healthcare visit, I have to charge, put a bill of somewhere close to $400 for that one encounter, so that I can hope to receive $150. And out of that $150, I can expect to pay almost 50% out into the cost of labor for getting that $150. So my net is only $75. Whereas I also have patients who come to me with no health care, and for them, for a complicated office visit, I can charge them just $75 for that one visit, and that's good enough. And often I can charge them as low as $35, and if they're just paying $35, I'm able to cover my expenses with just that $35 and move on. So one of the things that people don't understand, it takes a while for a lot of people to understand it. It's not how much you make, it's how much you keep that determines the success of a business. And if I make $1,000 but end up to keep only 10 of it, whereas I make $100 but can keep 80, I'm definitely more profitable the other way. So that should tell you, give you an idea why it is so difficult for a lot of practices to win and even start investing in higher levels of management, such as team building and leadership, because you're scrambling to just survive. You can't possibly start thinking of more idealistic issues of how are you going to reward your team for excellence. There is no possibility of excellence when you are only fighting to survive.
Okay, so yeah, that's a great example. I love how you broke that down to all the different pieces, all the ways everyone's paying everything when you're going through that insurance model. But how often do you run into the issue of the code wasn't right, or we're not going to pay for this because you didn't cross this T, or yeah, your contract said they paid you $150, but instead of paying you $150, they paid you $135, or some small discrepancy here or there, which of course over time can add up. But how much then extra time is there sometimes put into it just to get what you were supposed to get to begin with?
So that's about 25% of the time of my time is what is called reworking a claim to clear that. It used to be higher, but I have a very good team that picks up the errors right at the beginning and fixes it, and I'm proactively. So my clean claims ratio is very, very high, which is not common for most practices. Most practices have a clean claim ratio. A clean claim is a claim that goes through the entire Swiss cheese hold all the way to the jackpot without ever getting snagged. And that is a clean claim. And my staff are super good at threading those needle and threading the needle through those holes. So we are good at it. But I completely understand that is not the case for a lot of practices, especially young practices or new practices. They suffer a lot. And the way they try to manage is they outsource it to large groups that can do the job for them, but then they pay a larger premium of their income goes to paying for that cleanup service. So that's another cost. So all these costs kind of add up, and they erode the emotional experience of practicing medicine. Today we hear about physicians being burnt out, quitting the profession, going into early retirement, and so on and so forth. This is why they get tired of the hassle. I've yet to see a physician getting tired of actually seeing patients and fixing their problems. They don't get burnt out because of that. They get burnt out through the nickel and diming of every other thing that they do.
Yeah. I have a physician friend a couple of years ago now. It was about 4 years ago now. His spouse decided she was going to retire. Well, she was the one who basically was his office manager. She ran all his claims. She did everything. So he had a choice. He could hire somebody and had to pay someone twice as much as what he paid her to do it, because it was this family practice, right? It was a family owned and all of that to do it, or he could retire too. Well, then he had another epiphany. He goes, you know what? I'm going to continue to see people, but I'm not taking any insurance. I'm not taking Medicare. I ain't taking anything. I'm a cash pay guy. So they sent out letters to all their folks and said, you can still come to see me, but I don't take insurance. I don't do anything. I'm going to be a cash pay guy. So he did that for another couple of years until he was ready to retire as well. But yeah, he kind of felt guilty. He'd had some, of course, folks, I'm sure you do too, is he had for years and years and years. Some, some that he had almost delivered some of these kids, and they had grown up with him, and now all of a sudden he just felt bad, and he loved doing what he was doing. But I personally think the reason he finally retired after a couple of years is he had promised his wife he's going to take her all these places, and now she was retired and he couldn't go because he was still playing doctor, and she was like, when are we going here? When are we going there? When are we going to go get to go to the beach and wear a tie, right? But that is something, right? That is, you have to consider that. You have to, as a physician, whether it's you and with a bigger practice or a smaller practice, those people that process your claims are invaluable. It's almost like, would I rather have a good nurse on my staff or someone who is a magician to get me through the Swiss cheese? Wow. I've now got to choose someone who is a dynamo with taking care of my folks, or with a dynamo who gets me paid. Because if I don't get paid, I can't take care of folks either. It's a crazy place to be in, and it really shouldn't be that way, Doc.
I have a much more pragmatic approach. There's a lot about life that should not be the way it is, but it is the way it is. And so
it is.
Yeah. So, it is, it's like, the woulda, shoulda, coulda, but,
Yep.
But along came one little did.
Well, but this is, all of these things, this is just another layer of why healthcare is so complicated. And healthcare should not be complicated. One again, woulda, coulda, shoulda. But healthcare, as you mentioned earlier, it's really just the three pieces, right? It's the nurse, it's the doctor, it's the patient. That's the simplicity. And we're going to take care of you, and we're going to figure out what's wrong with you, and then we're going to try to fix that. We're going to work diligently to cure what's going on with you, not just whatever that treatment looks like, and not to just give you medications to cover up the problem, but to actually get to the root cause and get you well. That is the way that if it was that way, we would not have some of the chronic issues and problems that we do in this country right now. But when you bring those third parties into the middle of it that start saying, no, we have someone on staff for our insurance company that's going to make better decisions about your health than your physician team that's been working with you and knows you.
So, for example, right now, there is in the healthcare space, there are a couple of very, very good companies that are trying to use artificial intelligence and other cutting-edge technology to make the burden of taking care of patients better, but at the same time, trying to use the analysis of big data to predict which patient needs the higher level of care before they even need it. All right. And so most practices, so on paper, when these companies talk about what they would like to do, it is very attractive, the picture that they paint. But the practicality of it is, the other day, I had a colleague who was using something called Scribe Brain, which is an iPhone app that uses AI to capture his conversation with the patient and convert it into a progress note. Now, he was having difficulty integrating that into his workflow in a way that made intuitive sense without increasing his burden. That is just this little thing out here. Imagine the complexity of bringing in other elements from an outside predictive thing that will predict which patient is likely to require an intervention. And then if you start talking about, okay, if you already know which patient is going to likely to require an intervention before even the patient knows that he's going to need it, how are you now going to intercede? And what happens if you don't intercede? Like, are you now guilty of letting someone have an adverse outcome which you could have prevented because you had this technology that told you that he is going to get it and you did not take action to save him? What is your imperative in terms of obligation with that knowledge? So healthcare is not just providing someone knowledge, it is also processing that knowledge in a way that is actionable. And if you just provide knowledge and you are not able to process it, you only increase risk and liability. You don't increase outcome. You don't benefit. So there are so many cogs in the wheel that have to be fixed. And when you talk about leadership in that sense, there is a lot more than just the attitude, yeah, I'm going to go and build a supportive organization or build an organization that takes care of the greater good. How do you put all those cogs together in a systematic way that produces an outcome that is actually better than what you can do with just 3 people and somebody just pulling out a wallet and giving them the money that they need?
That's a great question, right? I mean, why are you putting all these other things in there when it should just be a simple transaction? And if it was a simple transaction, they're getting the care they need without going through all those hoops, right? There's no pre-authorization. There's no waiting. You, even as a physician, there's no wondering if you're even going to get paid, because you guys do a great job, but you still have some that don't go through, right? You still have some claims that don't get paid.
But this is one of the things that you have in medical tourism. Medical tourism is nothing but a cash pay model,
right?
Where where the people are going to a different economic structure, to a different country, and purchasing the service at a discount over there and coming back. And what you are saying is, all right, any system, it costs 90% of your cost is in the 10% of your last 10% of your outcome. You can achieve 90% of your outcome with just 10% of your cost. So what they're doing is they're taking the 90%, they're going to that other country, they're going to Brazil, they're going to Chile, they're going to India or Singapore, and getting their 10% of the cost, they're getting their 90% outcome, and they're coming back with that. And that essentially proves to you that you do not need this bloated infrastructure,
right,
of technology and methodologies and bureaucracy to produce the bulk of your outcome. You do need this for that small percentage. And in that sense, this is no different than insurance, where 90% of well people are paying for 10% of sick people. Like that, you have 90. It is the same Ponzi scheme, except that Ponzi scheme for the ICU, for the ICU-based care.
But this is what we've got, right? So this is what we've got. We're not going to change that. It's too ingrained into our society. It's too ingrained into our economy. When it's 20% of our economy, even if we could fix it today with a snap of the fingers, our economy would collapse, because it's 20% of our economy. If we fixed it today to where instead of a $400 charge, it was $75, and everyone paid directly, and we took all of those other entities out, we would lose some of the biggest companies in this country because we're talking about Fortune 5 companies, Fortune 50 companies, and we literally would collapse our own economy if we fix everything overnight. So we're not going to. In my opinion, we're not going to. But that doesn't mean we can't have a parallel system that works the way it should have to begin with, that is based on people that understand that if I pay $75, I can get the services. You're not going to have anyone stop me from doing that. In other words, cash is still king, or it should be. And if you're talking to someone, regardless of what the entity is, that doesn't recognize that, then I highly recommend you talk to someone that does understand it, a physician that does get that. Because that's showing good leadership, and that is showing someone that understands the issues and is looking to help you better access healthcare.
Yeah, we do that all the time. We already have a roster of vendors that, for example, we know which radiology facilities will get a chest X-ray for an economical rate, and which radiology facilities will agree to a 6-month payment plan for some of the more expensive imagings that we have. Because practicing in the Washington D.C. area, this is a tourist hub. International visitors come all the time, and I frequently will have my patients bring in their parents who are visiting them, who require some healthcare service, and these people are visiting their children and are falling sick without healthcare here. We will accommodate their needs using a small amount of cash and help them get the care they need. We will use GoodRx to get them prescription discounts. We will get them, we do that all the time. We have it's a piecemeal structure, but it is still through trial and error. We have built a network of providers who will work with providing services for cash pay patients, and we do that all the time. It's not heavily advertised. It is not. You have to work the system, and you have to know somebody in the system to tell you that, hey, this can be done this way. But it is there. It's almost like it's an underground.
Yeah. No, I agree with that. So to your point there, we were talking to a physician group out of Houston yesterday, and they do the same thing. They've kind of got a list of different specialists or different, maybe a radiology group here or someone that does this over here. And they've got this list, and they were asking us, who do we know that maybe want to be on their list? What they were looking for specifically was physical therapists and folks and psychiatrists or psychiatrist group. So they've had an easy time, say, finding some, and then have had a more difficult time finding others. But what I loved about it is they knew kind of what we do as far as building health plans and using direct contracts for that. And so they knew we had talked to groups like that. So they reached out just to ask us this question. Hey, we're doing this for our clients. Who do you think is a good person for us to talk to? Because we have this large group. They're kind of in a little bit lower income area of the Houston area. And they said, we want to be able to send people to folks. They still need these services, but most of them don't have insurance, or if they do, they have high deductibles and they can't afford to go see these folks. Who will do a contract with us that we can send our folks to? And they're interested in their own employees utilizing that as well. And since they have a decent sized group, I think they'll be able to possibly put some contracts in place. So I think there's a lot that can be done in that space, but I agree, you're right. It's kind of that underground thing going on right now. It's a lot of folks don't know about it, but it's certainly moving.
I would like to see it being more formalized in structure, but it is not. It's probably a few years away before it gets formalized, but you need a group or an organization that goes forward and starts putting together a network of like-minded providers across state lines, multiple things. And that is a slow endeavor. It happens. I know you are doing that in Texas.
Right.
I'm pretty sure it's happening in other states like Oregon and California. There are some groups that are working, but hopefully that will spread slowly.
Yeah, it's the move forward, in my opinion. That if you get the profit-minded folks out of the healthcare process, then now you've put the patient back in the middle. And once you do that, it changes the game for everybody. To me, it's surprising how many people don't realize that physicians, in many cases, especially surgeons, they practice at multiple different locations, right? They may have rights at multiple different things, including some independent surgery center type things, ambulatory centers.
Yeah.
And it's talking to enough of them now. I had a hard time believing this at first too. In almost every case, they make more money at the ambulatory surgery center, at the small surgery center, than they do at the hospital. But the cost of those procedures is dramatically more at the hospital than it is at these surgery centers. And it typically all goes back to overhead. Once again,
That's
like
right.
we were talking about before, the huge amount of overhead that a hospital has, they've got to build that into the cost. And once again, it's the difference between you saying $400 and $75. Well, put that same ratio together for a hip replacement. And now you're talking about, $80,000 versus $15,000 for the same hip replacement, but same parts, right? The same parts that we ordered for you,
Yeah.
and the same mechanic that's fixing you, same surgeon. And then you look at another piece of it, and that is that the outcomes at the surgery center are typically better with a lower infection rate than they are at the hospital because of all the moving parts over here.
Correct.
Because healthcare is one of the very few places that there's not the same correlation and you get what you pay for. Typically, if the cost of the healthcare is lower, it's better, which is weird, right? I mean, it doesn't make sense until you step back and look at it and understand why that really happens.
So, there was a guy by the name of William Baumol who said that in healthcare, increasing investment in expensive technology does not produce an increase, a corresponding increase in the value of the outcome. It just increases the cost of doing it and increases the failure rate by introducing more number of links in the chain, and
Right.
therefore more likely to get a weak link somewhere. This has been exhaustively analyzed, but the problem, there are some entrenched interests that fight the solution. I'll give you an example. Drug costs. Drug costs, I have, I go and take care of patients at nursing homes, or rather assisted living. So there was a new assisted living, and and in that assisted living, a 60-year-old Indian Patel, a guy by the name of Patel, he joined an assisted living, and he was an enterprising guy, and he got together and had a town hall meeting with the rest of the senior residents. And he got each one of them to contribute $150. That's it, $150. So 40 residents contributed $150 each. So how much is that? That is about $6,000 or something like that. All right. Oh no, 60,000. 40 into 150. No, 6,000. All right, 6,000. So $6,000. So then he took the $6,000 and he bought, using his frequent flyer miles, he bought a ticket to India. The $6,000 paid him 2 weeks stay in Mumbai, and he brought back one carry-on duffel bag and 2 extra large suitcases packed full with medication. For every one of those 50 people, they gave them their little list of, and he got them not 1 month medication. He got them a whole year's worth of medication of all their medicines for this $150. All right. And he got it. So he brought it all back and distributed it all to everyone. They know that when you buy glimepiride, which is a medicine for diabetes from Walmart, it comes in a case and you can peel the Walmart label off. And when you peel the Walmart label off, underneath is the label that this medicine has been manufactured in India. FDA has an office in Delhi, in Mumbai, in Bangalore, and Chennai. They have offices auditing the companies manufacturing drugs that come to U.S. India is the manufacturing center for pharmaceutical drugs for the entire world. It is the biggest manufacturing center. All your drugs are manufactured there. The same atorvastatin, the cholesterol medicine, that you pay 30 cents a pill, costs 30 cents for 60 days' worth in India. So that differential is huge. Do you know that Medicare is forbidden by law to negotiate prices down?
Right.
If you went into a store and somebody told you that you cannot negotiate with your car dealer the cost of the price of the car, you would throw a hissy fit about your American freedom and your rights, wouldn't you? But here you have the whole America. I can't negotiate my price of my medicine.
With the largest purchaser of medications. Medicare is the largest purchaser of medications.
And your tax dollars.
Right. And now they can, right? Now they can negotiate 10. That was finally done. They can negotiate 10. And whenever they chose the 10 that they were going to do, the companies that made those 10 all filed lawsuits against Medicare, against CMS, saying, "No, you can't do this. You can't make us negotiate." What? What? We like telling you how much it's going to be. We like charging you more than, and then you wonder, why do we pay more than anywhere else? Well, it's pretty daggone easy to see, right? And they're unapologetic. Yeah, they're unapologetic. The manufacturers are completely unapologetic about it and say, well, we got to charge you more because we've got research and development. We've got all these other things.
Why do I have to pay for you do it everywhere else too?
Of course, they say it's because those other companies won't pay more. Their governments, they're right. Their governments won't let us sell it for more over there because they don't have the same law, right? So what are we going to do?
Fundamentally, I'm being played by you. Yeah, exactly. So you are charging me because you can, because Europe will not let you charge them.
Right.
So you're going to charge me.
So exactly. That's your excuse. Once again, unapologetically. Now, one thing many people may not realize too is that the VA can and does negotiate, and they do a damn good job of it. They fall in line with some of the best negotiations in other countries as far as what they pay. I love this. They have the take it or leave it attitude. This is what we'll pay. If you want more, we're not going to do it. In other words, nah, sorry, we're not going to pay that.
So this aspect of American. So on one hand, you have this myth of capitalism and free economy, but there's nothing free about the free economy. How can you call it a free economy if you can't have negotiation?
Right.
That's free.
That's not a free market, right? That doesn't mean it's not capitalism. And capitalism as a general thing is not, there's nothing wrong with it. But if there's not a free market, then all it is profiteering, right? And all it is profiteering, because now I have no choice but to pay that a set higher price that is artificially inflated because I have no control over that. There is no market. If there is no market at all and everything is set, it's the same thing you have when the hurricane's coming in and the damn water is no longer $3 a case. Now it's $10 a case, right?
Right.
It's the same exact thing. And what are you going to do? Well, when people find that out, the government comes after them, right? And they say, there's no price gouging. You can't charge more now because of that. That's not supply and demand. That is actually price gouging. That's profiteering. You can't do that. Well, this is the exact same thing that happens right now, but the government just looks the other way.
So, there are a lot of redundancies and inefficiencies in the system. Some intentional, some non-intentional, some legislatively incorporated inefficiencies that need to be addressed in a systematic way with, I don't know when there will be the political will to do it. I sometimes think that the American population needs, we sit and rail about a lot of things in the public sector where this is an election year and we are all het up about so many things, but I can tell you there are some things that I would like people to get all heated up about. And one thing is this ability of us to lower our drug prices. That itself would make a huge impact in the cost of healthcare in this country.
I agree with you, but here's the frustrating part. We looked at how much movement there was in Congress this year on PBM reform. There was a lot of talk about it on both sides, and they had some of the leaders of especially the bigger PBMs. They had them on the floor of Congress there. They grilled them. They had lots of great committees, and these bills went through committee and had lots of strong push. And man, it looked like something was really going to happen. Smoke and mirrors, baby. Smoke and mirrors. Because when it finally got time to do something, it was quietly swept underneath the rug with, the growing and gnashing of teeth by some of the folks that really thought it was going to happen. And I was really fighting for you. That same old political BS, right? But nothing happened. And not only that, but we'll probably look at it again in November after the election. That's convenient, isn't it? Come on, man. I mean, how dumb do they think people are, really? I mean, these are huge things, but I agree with you. Unless there is more of a cry about it, unless people just, get on their tractors and start driving to D.C. like they do for whenever they're mad about something else, we're just not going to get that change. And there is no doubt that the effect of the cost of medications has on the cost of healthcare overall is dramatic. It is absolutely dramatic. And we're going to have to see those changes. Now, but here's the good news. I will tell you, this is some good news. And this is what people don't know, is there are many ways to access your medications in a much more fiduciary way at lower cost. You don't have to use those big PBMs. There are other fully transparent pass-through type PBMs out there that you can use there are a number of groups like Cost Plus and Scriptco that are pharmacies that are direct to the manufacturer. There's not even a PBM involved in that in many cases. So you've got groups out there that are providing solutions. We've just got to get the word out to more people so that they realize that there are better ways to access the same medications overseas. Once again, medical tourism in a whole different way. The law says you cannot get your medications overseas unless the FDA has a presence. What did you just teach us earlier? FDA's got a presence in India. FDA has a presence in many other places where these medications can be shipped from legally. And there's many avenues to do that. So I know a number of clients that are getting Ozempic or Mounjaro, and they're getting it from Canada, and they're paying less than 50% of the price that you would pay if you bought it here.
Yeah, that's right. I can go on and on. What I think the single biggest impact would be to have one repository of all this information easily available for people to access. Right now, it is like an underground, whispered campaign. You need to know, who do you know who can tell you how to negotiate the healthcare maze. I would love it if I had access to a single resource where I just go into that website and I just type in, okay, this is my zip code. I need to send a patient XYZ service. Who are my options? If I can get that, that would be something that would be of value.
And you know what? There's folks working on that stuff. I know personally of folks working on that stuff, but it's usually in select areas, right, Doc? That's the problem. Yeah, just like you're doing it, and we're doing it, and there's other people doing it.
If somebody if somebody could build a central repository that catalog essential services in every zip code area in the country, major. And you start with one area, then build it to the next, and so on and so forth. I mean, I would love it if they could do it state by state. There are 46 states, and even if you do one every, 2 states a month, in 2 years you would have everything put together.
Yeah. And of course, the one of the issues that people run into, and I know you've probably run into this too, is there's a lot of phone calls that you'll make where people are not agreeable to do it. That there's a lot of wasted time in there where people will not, they're stuck in the system. In other words, they're just not, they don't think there's value in it because they haven't dealt with it, I guess, enough in a way. It's amazing to me still whenever we'll work with a physician and say, hey, we got someone we want to send you, and it's going to be a cash pay, that will just tell us we don't do that. We don't do cash pay. And many of them now, one of the things I think that's interesting, many of them think it violates their contract with insurance companies.
No, it doesn't.
It doesn't. Of course it doesn't. They also don't think they can do a direct contract with you because they say it'll violate. Well, how does it violate the contract? You take like 10 insurance companies. It doesn't violate any of them. You have to take one of the other ones, but you're saying if you take cash or if you do a contract directly with an employer or with a group like us, it violates it? No, it doesn't.
It's a myth.
It's a myth. That's exactly right. It's a myth.
And the insurance companies tell you that it violates, and therefore they believe that. Just because they say it doesn't make it so.
That's exactly right. Here's another one for you. And I know you guys don't do this because you've already told me y'all will take cash. You'd actually rather do that. But there are physicians, hospitals, and groups that will tell you if you have insurance, you must use it. You can't pay cash. You can't choose not to use your insurance. You have to use your insurance. That is absolutely not true. That is absolutely not true. If you don't want to use your insurance, you don't have to.
That's right.
Because there's times whenever if you've got an ACA plan right now with a $9,450 out of pocket or deductible, and you go to the hospital or you go to the surgery center and you use your insurance, it's probably going to cost you $9,450. But the actual cash procedure may cost you $3,500.
That's right.
You're saving tons of money, but they have to charge way up here to get paid way down here. So that same procedure they're charging $30,000 for, which means you've got to meet all your out of pocket. They're having to kick it up by 10% just so they can get enough to cover all their expenses. Just like you were talking about earlier. So it's but you've got to know these things. You've got to understand these things, because if you walk in there and they tell you have to use your insurance, you don't know any better, right? You just don't know any better. You leave them.
And if you are a 70-year-old retiree who's mildly forgetful of things and who's a little nervous about doing the math and things like that, they can easily get confused and bamboozled by all of this. It's easy.
Well, almost anybody can. It's so complicated. You're like, oh, well, I guess that's right. I mean, I'm telling you, I've had people across all age groups that have told me this, and they're like, well, that's all I can do. And then when you tell them they don't have to, like, well, I don't want to really argue with the hospital. I mean, I'll just do it. I'll just pay for it. What are you talking about? Why would you do that? Stop. You're just feeding the beast, right? You're just continuing the process here. If we don't make changes, if we don't put them in their place, as it were, and tell them you're wrong, I don't have to do this. Because you know what? You may be talking to a billing person or an admin person that was told that, and they don't know any different. That's what their boss told them. They had no idea that you could do that. So you're not going to convince them otherwise because they don't know. If you run it up the flagpole, though, they may say, you know what? Wow, I've been telling people for 5 years they couldn't do this. I didn't know you could do that. That's the way I was trained. You were trained that way for a reason. They don't want you to do that. They want this bigger amount. They don't want the lesser amount. We know what we're talking about, Doc. Y'all, if y'all are listening to us, y'all better listen to us. Huh? What did I say? So let's jump back over to the leadership aspect of this and talk about, as a leader in healthcare, we have kind of beat all these problems to death. We beat this horse, so we know what's happening here. With this leadership aspect mindset, and going back to that triangle you talked about with the patient, the doctor, and the nurse, what can they do to affect change here so that they don't get lost? All of them or any of them get lost into this system?
So the way I can tell you what we do at our clinic, and what we do is we looked at the why of why we are in healthcare. And this is something that a lot of people don't. Everyone can tell you what they do, how they do it, and who they do it with. But most people don't understand why they are doing whatever it is that they're doing. One of the things that I spent time in my clinic and getting my team aligned was to get everyone to understand why they were reporting in the clinic every morning. And I call that the grounding principle or the grounding narrative. See, we all live life in a story. Life comes at us as events that come to us, and we see this. We have 5 senses. We have a body that allows us to perceive the events of life as they come to us. But that's not just it. As these events come to us, we have a mechanism in ourselves, each one of us, that makes a story out of it. It makes a judgment, an assessment, an interpretation, puts a value to it, puts a hierarchy to it, compares it with something that you like or you dislike, and puts a certain decision about it. This story about the events just happens. For the most part, the stories of our life are not premeditated, meditated. They are just thrown out automatically, like so many beads of sweat pouring out of your skin, or some other bodily emission. You don't have any control over it. The story just pops up. And usually the story is predicated by some other past event that has triggered something similar, right? Most of us conduct our businesses just based on that. Not just our personal life, even our public life, our professional life is based on all these stories. What we did in our clinic was, we said, you know what? We're not just going to let any goddamn story determine who we are. We're going to determine what is the story that defines who we are. And we're going to understand what that story is. And the story we understood as who we are is the reason why we are doing this is to empower people. So empowerment became the grounding narrative. Now, by that, we made a decision. It's no good to be empowering to the patient and disempowering to ourselves. We got to find a way to empower everyone. That means, in this triangle, the physician needs to get empowered, the nurse needs to get empowered, and the patient needs to get empowered, all at the same time. And that means we are not going to just be happy today empowering the patient and going home completely invalidated or disempowered ourselves. We are not going to be happy just validated and empowered ourselves with a completely disgruntled and bird up, flipping the bird to the patient. All right. We are not going to go home empowered physician, empowered patient with a nurse willing to basically, hang herself from the ceiling rafters, So that's not going to happen either. So we're going to find a way such that each one of us gets value out of this equation. And that is why we are here. So that is why you are showing up this morning at work, to make sure that everything you do, make sure that everyone goes home a winner and no one gets home to win at the expense of somebody else. Once we started doing that, we said the only way we can do that is we decided we are going to use a policy I called it the Three Musketeer policy. The Three Musketeer policy is one for all for one. All right. That was, the Alexander Dumas movie or the novel, The Three Musketeers, D'Artagnan, Athos, Porthos, all those guys. Anyway, so the one for all for one, we decided that in our team, everyone works always to make sure that we watch out for the success of everyone else. To ensure that the one for all for one policy works, I stepped up and I said that, from this moment onwards, I'm going to assure you this, that no matter what mistake you guys make, I will bear the cost of it, and you guys don't have to bear the cost of your mistake. I will bear the cost of your mistake. Guess what? When I said that, automatically what happened was everyone said, you know what? I don't want to make mistakes because you are bearing the cost. I don't want you to bear. Because the one for all for one policy prevented them from making me bear the cost. You see how empowerment becomes automatic?
Right.
Now, But empowerment would not happen if we didn't, you make that our grounding principle. So every action we did, we asked ourselves, does this work in this system? And if it doesn't work, we said no. So when an insurer came and said, this is our rate, we said, you know what, I won't take this. All right, I won't take this. And when they said that, oh, we are going to deny you this medication or that medication, we went around and told the patient, listen, this is your plan. Your plan is telling you that you can't have this. And this is why I think you should have it. And here are the things. And then I got the patient to participate in defending their care. So in this way, we worked the system. As a result, we went home much more gratified. And does it actually make... See, I see 20 patients a day. And I go home happy and satisfied at the end of the day. And so do my staff. This happens because of this system. That's all we did. That's where I said leadership. Now, you can do this across the board in growing levels, but at every point, you need to find two things: a grounding narrative, and then build that grounding narrative to be supported by the Three Musketeer policy. It always works.
Wow. It's so simple, but it takes so much. It takes full dedication to it, right? It does. It takes full dedication to that, because one piece of that falls off, then the whole thing spins out of control, right? The whole thing spins out of control if your team, if the empowerment is not there, if they're not bought into it. Okay. So when I say it spins out of control, if someone's not bought into this working.
Let me explain to you what it takes to make it work. My front desk lady is a girl who lost she's paraplegic. She doesn't have her legs. At work, she has a scooter that we got her, the mobile chair. But that's bought by the clinic. The clinic bought it for her to make her work easy, so she doesn't have to struggle to move around. And we got her $40,000 robot legs that allow her to walk at home. See, we do these things to each other to make sure that they are validated, that they are actually they actually are part of the team. You see, it's not just like, oh, I'm going to give you a bonus check. In my clinic, my staff get a bonus every 3 months. And the bonus is not small. It's $1,000, $1,500 each person. And the clinic bears the taxes of that. So it's actually $1,500 in their pocket. The actual cost is higher. See, these are things that we do for our staff. It is important. So, it is not simply putting a button on your shirt and saying, I'm empowered. That is not the way we do it.
Right.
We live it.
Then it doesn't work, right? I mean, if you just tell someone they're empowered, but you don't actually empower them, but you really haven't done very much.
How does empowerment look like? How does it feel like? It feels like this. It is the experience.
And it is. It's the experience of it. Knowing your value, right? Knowing your value, your opinion valued, and every what you're bringing to the table is valued.
That's right. And so we do this across the board, and I have not seen practices do it for their staff. They don't. The doctor goes home with $250,000 in salary, but but the staff are trying to make ends meet at $30,000 a year. That is ridiculous. That is ridiculous. You can't do that.
Yeah, but it happens all over, right? I mean, that's what you just described is 90% of the practices, maybe.
Yes, and that's not right. And as long as you do that, you will not transform healthcare to a higher purpose of its existence.
Yeah, because there is no empowerment in that situation. In fact, it's just a job. And if I get offered a few $1,000s more down the street, then I'm gone. I have no reason to stay here, right? There's nothing to keep. There is no empowerment. I've got to empower myself. So I'm going to empower myself to make $4,000 a year more by going down the street and working at this other place.
That's right.
And then they see the same thing, but they're still on the same hamster wheel, right? They're still on the same hamster wheel because they're just going from that model to another one with the exact same model where the idea of empowerment is not there. But their thought is, you know what, I'll get a couple more years experience here. Then I can get another raise whenever I go work somewhere else with even more experience.
So it's as long as your fundamental paradigm is how can you extract value without paying, without validating for it, you will only be mooching from job to job. You'll be mooching this, then you'll be mooching that. You won't be, you really are not growing.
Right.
But so one of the things we decided right from the beginning is this is how we are going to conduct business. So my practice succeeds. Whether it's a pandemic or whether it is an everyday care, we win. All the time we do it. We've been doing this now for 30 years and we'll do it. You know, I've been a doctor for 41 years. But that, in a nutshell, is leadership.
This has been a very, very interesting and enlightening conversation, Doc. I really do appreciate you taking time to be on for a second show, because I think that you have some great insights, you have some great views on things, and that the dramatic differences and things that need to change in the healthcare world could definitely be impacted by your views. Folks, I hope that you have appreciated the time that Dr. Iyer has given us. I really do appreciate your time being with us, Doc.
Thank you. Thank you for having me. It was a pleasure.
Yeah, absolutely. Let's definitely stay in touch in the future as well, because as things come to pass in this industry, I think it would be great to get your view for folks, even if it's a short little video that we can do together. I think it would be great to get your view on things in the healthcare world as well, sir.
Wonderful. Yeah.
All right. So, gang, thanks again for being with us. And if you have any questions for Dr. Iyer, don't forget you can go out there and find him. He is all over the place. He's got his website, Facebook, Instagram, LinkedIn, Twitter, his website to go out and check out his clinic. To go check him out. And you can also check out his clinic is Dr. So for doctor, Iyer.com. He also had his great, really cool book that we talked about a lot last time called The Reaper's Dance, that takes a look back at COVID and all the craziness that happened there. He digs deep into that. We dug deep into it last episode. So if you didn't hear our last episode, you can jump back over to that and hear us talk about that, because that was a pretty fun talk as well. Don't forget, we got a number of other things going on. You can always catch us on LinkedIn and various different things. Every single week, I kick off Mondays at 10 a.m. Central Time with the Kickstart. That is a live update of the news stories that are affecting the healthcare and health insurance world. I do that every single week, 10 a.m. Central Time, Monday. It is called the Kickstart. Helps you kickstart your week, knowing what's going on, helps you be better educated on the healthcare industry and all the things that are going on. Want to make sure that you know what's up so you can keep your clients informed, keep your staff informed, You got to know what's going on, or else it's going to eat you up, folks. There's a lot of stuff happening in the healthcare world. And then, of course, we have our monthly audio room on LinkedIn called Why Does Healthcare Suck? That's right. Why does healthcare suck? We dive into the different aspects of healthcare. Some of them we've talked about today with Dr. Iyer, but we don't just talk about them and bring in interesting guests to talk about their experiences. We also talk about solutions. So please join us. It's typically the last Tuesday of every month that we do that, 11 a.m. Central Time. And of course, if you want to join up to get the Health and Wealth Power Hour delivered directly to your inbox, you can have that done by going out to hwpowerhour.com. That's hwpowerhour.com. Subscribe, and it will show up in your inbox every week. Thanks again for being with us, and we'll catch you next time on the Health and Wealth Power Hour. We are out.